Hi, everybody. We'll give everybody a moment to make their way in. We have not one, but two presenters tonight. So we have double the fun, right? It's going to be a very exciting evening. So I know people are making their way in, but we will get started. So welcome to tonight's Woo You event, How to Diagnose and Manage Dry Eye with Corneal Nerve Dysfunction with Dr. Cecilia Ketting and Dr. Vin Dang. Welcome, guys.
Excited to be here.
Yeah,
Yeah.
I'm back. I'm back again. I was here last week. I'm excited to have a friend. It's more fun.
Is your screen moving?
Yeah.
Is my screen moving?
Yeah. Do you
No,
want
did
to?
it do something?
No, you can move forward though.
Oh,
There we go.
perfect. Yeah,
There.
just yell at me. Sorry. I
Oh.
was
I'm your host, Dr. Jennifer Stewart. Thank you to Vital Tears for exhibiting at tonight's event. Just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARPA with OE tracker numbers. We'll also display the QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks and ask questions throughout the presentation using either chat or Q&A. Here's where they are on your phone. I was gonna say whose bio goes first. I wasn't quite sure. So,
You do not have to
so
read the whole thing.
I'll pick and choose. So there's so much
Beautiful.
on there. So welcome back, Dr. Ketting. She's an assistant professor at the University of Colorado School of Medicine in the Department of Ophthalmology in Denver. Her primary focus is anterior segment ocular surface disease, neurooptometry, and perioperative care. She does a lot of clinical research and has served as extern director and adjunct faculty for several schools and colleges of optometry. She's a member of Intrepid, a fellow in the American Academy of Optometry, a diplomate of the American Board of Optometry, an active member of the AOA, and has served as both local and state officers within the AOA. She was named Young Optometrist of the Year by the state of Virginia. She lectures locally, nationally, and internationally at conferences, contributes articles, and serves on editorial board for multiple publications. Welcome back to Woo You, Dr. Ketting.
Thank you. You didn't pick and choose. You read the
I
whole
know.
thing.
There's
You
too
missed,
much.
you took like two words out.
There's too much. How do you get rid of some of that? So here are
I,
her
I
financial disclosures.
all mitigated. We're good.
And now, Dr. Vin Dang, I will read your whole bio. So, he's an optometrist practicing in Bakersfield, California, with a unique clinical focus on ocular surface disease and dry eye. Born and raised in Paris, France, he earned his doctorate of optometry from Southern California College of Optometry. In 2016, he received his fellowship with the American Academy of Optometry. As director of Dry Eye Center at Empire Eye and Laser Center, he's a specialist in ocular surface diseases, advanced refractive eye surgery care, and glaucoma. He's contributed to optometric journals and lectures on ocular surface disease treatment and management. He serves on the advisory boards assisting in the research and development of dry eye therapies and crafting disease management protocols. He's a member of the American Optometric Association and past president of the Kern County Optometric Society. He volunteers nationally and internationally with One Sight and Vision to Learn. Welcome back again, Dr. Dang. I will turn it over to you. These are Dr. Dang's financial disclosures. I will turn it over to you and I will be back at the end.
Wonderful. Thank you so much for the warm welcome. Vin, good evening. Good to see you.
Good to see you, Cecilia.
Um,
Exciting. Thank you, everybody,
so
for being here.
yes, and thank you all of you guys for joining us on a lovely Tuesday evening. We're not competing against Monday Night Football, so I think we're doing a little bit better today than yesterday would have been. Yeah. We're going to be talking about how to diagnose and manage dry eye, but more specifically, not just any dry eye, right? Dry eye with corneal nerve dysfunction. And I think, Vin, you would probably agree with me when you say that there's probably a lot more of our dry eye patients who have some corneal nerve dysfunction than we probably realize.
Oh, absolutely. Yeah, I think that it's I mean, it's dry eyes. We say that it's kind of like everywhere, right? But it's
Yeah.
like with corneal nerve dysfunction, I think it's a little bit underdiagnosed for sure.
Yeah. And so, just to kind of kick us off, we've got the beautiful DEWS 3 definition of dry eye, right? And so it really hasn't, dry eye disease really hasn't changed as far as how they're defining it. They've made a few small word changes just to kind of make it a little bit more poignant and a little bit more what we're understanding, and really that's the symptomatic portion of it that was added to it. But we still know that it's multifactorial. We know that it's a loss of homeostasis of the tear film, ocular surface. We can get instability of the tear film, hyperosmolarity, inflammation, right? The big words we know, inflammation and damage. But also remembering, and part of what we're here to talk tonight about is that component of dry eye, which is that neurosensory abnormalities, that's also a factor with dry eye disease.
Yeah, I think
So
that was great because like in like when they came out with Deuce 2, that's when they added that neural sensory component,
it
right?
is, yeah, because that was not there before. And honestly, the I feel like hyper I have to remember, right? Because this is 2017 when that came out. Hyperosmolarity, I don't believe was in there either.
No, no.
No. So we joke, right? Finn, who has dry eye?
Well, I have a saying, right? In my clinic, all my technicians, they know this. That when I see the patients, I don't have to prove to them that they have dry eyes. They have to prove to me that they don't have dry eyes. That's how prevalent it is.
I'm with you. You have dry eye until proven otherwise. You're in Bakersfield, which is a
Yeah.
drier portion of California.
Yeah. It's not all palm trees and sunshine and beaches, everybody.
No. And even with that, I have patients. So I live in Denver now, right? But I used to live on the coast in Virginia Beach. And people are like, "Did you see more dry eye now than you did in Virginia Beach?" And I was like, no, honestly, no. All right, so everybody's got dry eye. There's lots of different things that starts to add to the cause of this, right? It's multifactorial. We talk about environment. Environment is a big thing that I spend a lot of my exam on, trying to figure out what is in my patient's environment, especially if something's changed with their symptoms. Um, what about you, Vin? How much are you?
Oh yeah, absolutely. I mean, like today I just had a patient and she was saying that like, yesterday she spent 5 hours out on the gun range, right? It was just like dirt and dusty,
Oh,
windy.
yeah.
And then just like when I saw her today, she was like, my eyes just feel worse. And it was just basically her cornea was just like, like 2 to 3 plus PK, and when
Was
I'd
not
seen her
happy.
actually at her initial evaluation, she was actually better. So I was just like, oh, so environment, huge, huge factor.
Huge. Yep. And I could tell when we had our forest fires popping up, just because everybody was coming in or texting or sending messages saying, "Hey, I'm not doing so great right now." And I'm like, "Yeah, no one is. Absolutely know what the issue is." We got to remember environment's a big part of it. And we kind of come down to the dry eye cycle being both the evaporation and inflammation. It doesn't matter where we're all familiar with this cycle, right? At this point, it doesn't matter where you enter into it. Excessive tear evaporation leads to epithelial cell desiccation that leads to inflammation that kind of feeds back into it. One of the other things that we have to think about is all of that in the context of the corneal nerves, and what we're going to be talking about tonight is going to be part of what leads to the damage and dysfunction. Not in every case, but constant chronic dry eye disease can lead to that damage of those corneal nerves. And being, I'm a person, Vin, when you go to look at your patients, so we know that DEWs and many of us kind of break this down into evaporative versus aqueous deficient. I don't necessarily say, hey, it's this specific thing in my brain versus this specific thing, because many times it tends to be both.
Yeah, yeah, for sure. So like, I mean, like I have this thing that I type up, in my charts where I always say mixed mechanism, right? Because the thing is that it's not just, one thing or another, right? It's never just, strictly aqueous deficient. Even with your like, when you think of aqueous deficient dry eye or your Sjogren's patient, right? Even those patients, they have some form of some component of evaporative component, right? So I think that it's always better to kind of look at it from a big picture standpoint. Just kind of definitely assess all of the different types, but not just say, hey, you have this or you have that.
Yeah, absolutely. And also remember that just because someone has one right now doesn't mean that in 6 months, a year, 10 years from now, they may not develop another problem. Going back to our environment that we were just talking about, right?
Sure.
So, yeah, we know that they're not mutually exclusive. They can definitely be both. Then, will you walk us through what about when it's not just dry eye? What about this corneal nerve problem that we're talking about?
Yeah, so I mean, we have to remember that like the cornea, the ocular surface, surface has the most concentration of nerves, and so these nerves, when they get introduced to like some form of like trauma or anything like that, it's going to cause some issues, right? Obviously, the cornea is avascular, but it's also very sensitive to pain, right? So you have these like nociceptors on them that tells you like, when your patients like they have a piece of lint or a small little metallic foreign body, right? And they're like, oh my God, doc, I have like this rock in my eye. And then you take it out and you show them, they're like, what? That thing is so small. Why was it causing so much pain on my eye? Right.
Yeah.
And that just because I kind of like say that, the it's like a paper cut, right? I mean, a paper cut is like it should be nothing, but it hurts so much because of the nerve endings, right? So all of
Right.
those you have on the surface causes these problems. And when you have any sort of insult to it, it kind of travels along the trigeminal, nerve, and then you got the afferent pathway, and then the efferent pathway that kind of stimulates, the lacrimal gland, meibomian glands, and then the mucin on the goblet cells that produces the mucin. So, I mean, it's very important, right? So when
Yeah.
you have severe dry eye, sometimes that chronic insult can eventually lead to this dysfunction of the nerves.
Yeah. And I think it's worth mentioning two things, right? You mentioned nociceptors, right? Those are the ones that are giving us our noxious heat or cold, like the high ends of heat or cold, mechanical stimuli, something getting in there. And that's kind of where we get that pain response. But we know that there's other types of receptors, and we'll talk a little bit about some of them as we go through. But also remember that that trigeminal nerve is super long, right? We know it goes from the eye all the way down, back through the neck, and up to the brain. And if you sustain damage anywhere in that nerve, you can get anterior grade or retrograde, right? It can move, that damage and feeling can move forward or backwards. So sometimes, and we're not getting into that tonight, sometimes literally a pain in your neck can actually be a pain in your eye. And that is when these kind of get really tricky. And I do believe I've got the prepare cane test in here, so we'll talk about that as well, because that's kind of where that one comes in. I'm gonna let you, I'm gonna let you keep rocking.
Yeah. So then when you have these corneal nerves, their job is to basically give you feedback, right? I mean, it's just it sends a feedback to your brain and says, hey, something's wrong, right? So it's whenever there's a signal that says, hey, there's damage, something is happening, whether it's from cold or from pain or from anything like that, then what it does is it says, okay, something's wrong, right? I need to fix this, please. It sends a signal blinking like crazy, right? So you'll like start sending this like protective blinking pattern, and then you'll have a lot of like tear production, right? So it's like your eye starts watering because it's trying to like almost like maybe flush out the foreign body or try to heal the ocular surface. And then the second job of the nerves is to sort of like release these like neuromediators that basically helps the epithelial cells kind of turn over, right? So you got that, you got all of these these neuromediators like substance P and neurokinin A, all of these that are part of the some of the growth factors that are in the body that basically helps heal the epithelium and turn over the keratinocytes and the epithelial cells. So that's why the jobs of the nerves is very, very important, right? Without that feedback, without the signaling to, if you have any sort of dysfunction, that's when you have a breakdown in the ability for the eyes to kind of help heal itself.
Yeah,
And then we
absolutely.
move on to specifically one of those specific neuromediators is called the nerve growth factor, right? So What this nerve growth factor does is it basically helps stimulate the regeneration of the sensation of the nerve itself, right? So when you have this healthy sensory nerve, that's when you're able to sort of trigger this process of blinking and telling your body to say, hey, blink, telling your body to produce the tears, and then telling the cell proliferation and differentiation, which is that's all of this is sort of part of this like loop that's basically helps the surface help in terms of injury, right? So without this nerve growth factor, you're sort of that you have this sort of missing link. You're not producing enough tears, you're not producing enough of cells, and that's when you get like persistent epithelial defects. You get maybe potentially like punctate keratitis first, then into those melts and stuff like that.
And it's not just nerve growth factor, right? We know going back to the previous slide, there's all of these different neuromediators, but this is definitely one that we have more experience with. And we'll talk about right now, the use of recombinant nerve growth factor is, a nerve growth factor to mimic what we naturally make, right? Is what one of the things that we have to work with. So that's why it's definitely worth mentioning that that's part of why we have those treatments. So essentially, you've already kind of talked us through this, but when we have corneal damage, or we have damage to that trigeminal nerve, right, we start to get impairment of those two things that Vin was talking about, the trophic supply, which is all of those neuromediators being released to help with the proliferation, differentiation of the epithelial cells, the function of our limbal stem cells, helping with the corneal healing, all of these things, right? And that can lead to spontaneous corneal epithelial breakdown. And then we also get an impairment of the trigeminal reflexes, which is what helps to produce the tear film. It helps to make sure that we're blinking to protect the eye. And so when we have a reduction in those two things, that also can lead to a spontaneous corneal epithelial breakdown. And this then leads to damage, dysfunction of the trigeminal nerve on the cornea, and that's where we get that neurotrophic keratitis. And we've got this beautiful photo over here that I hand drew. Don't make fun of it. The
Oh
ears
no,
are a
that's
little
right.
lopsided. I know. Um,
I
but
love
just
it.
remind,
I
just
love it.
I know, but just reminding ourselves of kind of essentially where we have the different branches of our trigeminal nerve. And so why someone may have damage, we're concerned more specifically with V1 because that is what is part of the corneal sensation. That's also, as we talk through some of the treatments and things that are utilizing neurostimulation and neuromodulation for dry eye, thinking about, remember, we've got that lovely little branch that's on the inside of the nose as well.
You know what I really like about that picture is because I actually kind of use that whenever I'm talking to patients that have like shingles, the
Yes. Yep.
doctor. I always kind of like, and I'm always kind of like, okay, well, the branches are kind of like
Yep. I
this,
do this.
right?
I do
And
this.
then I just like that's how it goes, and that's why your eyelid is swollen, and that's why I love your picture because it just that's where the trigeminal nerves are, right? I mean, that's why V1 is so much more affected. That's why they was like, oh, but I like it all started in my scalp. I had like these like
Well,
weird itchy lesions.
and why some patients will be like, well, and this is always interesting because you think the primary care doctor would know. I've got shingles on my arm, but I'm concerned that they may have it in their eye. No, I think we're probably pretty good. And then
Yeah.
there's also the question of if I touch an open sore and touch my eye, is it going to go there? Well, unless all of a sudden you activate that trigeminal nerve, having it probably not. But it's still not a good idea. Don't do it.
Yeah.
Yeah. Okay. Um, Finn, do you even think this is an accurate statement at this point? Fewer than 65,000 in the US. I think
No.
between the two of us, we've got 65,000
Yeah.
NK patients.
Yeah. 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 For sure. I mean, I think that kind of goes back to where we talked about how I think it's a little bit definitely underdiagnosed, right? I mean, it's just a lot of it is probably masquerading itself as people think it's just dry, right?
Yeah.
So
And unless you check corneal sensitivity, you don't know.
you know,
You got it.
absolutely.
So etiology, lots of different ways that this can kind of come about. Going back to what Fen and I were talking about with the trigeminal nerve, thinking about damage anywhere within that, neoplasms, aneurysms, strokes, TBI, degenerative disorders of the CNS, right? If it affects anywhere within that trigeminal nerve, you could end up with a neurotrophic keratitis.
I
People,
actually, well,
yeah.
speaking of that, I actually had a patient have an acoustic neuroma, right? So
Hmm.
when they did the surgery for her acoustic neuroma, they
Severed it.
severed the genital, and then now she can't blink. She
I
can't,
had one of those.
it's, yeah.
She ended up with a trigeminal nerve graft on her eye.
Oh, wow. That,
Yeah, I know. Yes. So
like,
those are
I
ones,
mean, the neurologists, the neurosurgeons, they don't think about that, right? I mean, they're like, well, you're cancer free, you're good, right? But
right? It's the bird in one and stone in another. I don't know what that saying is, but something like that. We'll go with it. The most common though, what is the most common that you see?
I mean,
Or most
diabetes.
diabetes?
These herpes, right? Those are going to be the
Yep.
big ones, right? I mean, those are like the ones that you're going to see in your everyday practice, right? I mean,
Yeah.
like if you got a diabetic exam here from your primary care, for me, it's like first thing is like, you
Yeah.
probably have some form of NK, right? And actually, that's how I describe, NK to the patients, right? Because NK is such still a new thing people don't really know about, right? But when I tell them like well, it's kind of like neuropathy, right? And they're like, oh, I've heard of neuropathy, right? And like,
Hmm.
well, does your feet tingle? Does your toes tingle? Do you feel numb sometimes?
I think the
That's
diabetic patients get it the quickest because those are also the ones that I ask, do you have any tinglies in the fingers and toes? And if they do, I'm automatically checking that corneal sensitivity because they've already got neuropathy.
exactly, right?
Yeah.
So when I'm explaining to them, they're like, "Oh yeah, yeah, I kind of know what neuropathy is." Yeah.
Hmm.
Well, I'm like, well, the surface of the eye is the same. You've got all of these nerves that are like dead now, right? You don't feel it. I'm telling you, you've got like all of these scratches, and you're like, "I'm good. I don't feel anything. Everything's good. My vision's a little blurry sometimes, but I'm good." Like,
Oh, glad that's going well for you, man. But yeah, I mean, you guys can see this slide and we've heard it. Think about anything that could cause chronic inflammation. Postherpetic and diabetes are by far probably the two most common. The next one is going to be the ones that are referred by my glaucoma specialists who have done so good saving the back of the eye, but have unfortunately left the front a little bit less than desired.
yeah,
So those are definitely ones. Chronic contact lens wearers or over wearers, right? Contact lenses in themselves don't necessarily cause damage if they're fit properly, but we know that patients don't always do everything proper. So we just have to think about it. And then with the classification, so when we actually get into this, and we'll talk about corneal sensitivity testing in a little bit, but there's three stages, right? We've got the stage one, stage two, stage three. Stage one, I think everybody can probably look at this and go, yeah, I saw like three of these today, right? But what's the difference? How do I know it's NK? Well, if somebody's glowing like a Christmas tree and like Vin said, they're not feeling it and they're saying, I'm fine, that's not right, right? This is the cornea. It's highly innervated. They should be feeling it. So that's someone you want to check their corneal sensitivity, and that's how we know. Stage two, we've got a persistent epithelial defect. And stage three, guess what? Bacteria made a little home in that open wound, and now we've got an ulcer. Then, have you seen or do you use the NKSD classification? I like it, but I'm not using it.
yeah. I think that the Mackey classification is
It's
a
so
good
easy.
starting point, but it's very strict, and it misses out on a lot of the sort of earlier stages.
Yeah. And the
So
nuances, right? Because
exactly.
you'll have a patient who's stage two, but you can start to see some stromal haze that's going on, and you're like, well, you're kind of like could be going into three. And I
Mhm.
think that I just use descriptors versus using
Stage.
this.
Yeah,
Yeah. Yeah. But it exists. We're here to show
exactly.
you. So then I want you to walk us through how do we determine the underlying causes?
You've got to do your diagnostics exam, right? You gotta use your slit lamp. You don't have to have any fancy tools, right? And it's always like, I always have colleagues guys asking me like, how do I start a dry eye clinic? it's like you've got all of the tools. It's right in your drawers. You got it in your exam room. You got to do a good slit lamp exam, right? I mean, because if
100%.
you don't, you're gonna miss, right? I mean, vital dies, right? Simple.
Thank
Vital
you. You
dies.
hit it.
Vital,
That's what I want.
you don't
Vital
need
dyes.
you don't
And
need anything fancy.
you don't even need lissamine green. I mean, look, okay, if you can, great. It's also hard to get right now, but fluorescein,
Yeah.
please. Yeah.
Yes. Because it's
Yep.
like, I mean, you'll miss so many things, right? I mean, it's just I mean, unless you have really, really, really good like slit lamp skills, it's you'll miss because it's just, I mean, it's why make your job harder, right? Just put a little
Yeah.
bit of eye in, and then you're gonna be like, whoa, I missed all of that stuff on the bottom by the limbus or all of the stuff on upper, right? And that's the
And
thing.
and
Do
it's
you have
really important to describe it,
Mhm. Mhm.
right?
You're
Because
gonna
in
have to,
this,
yeah. So like, I mean, when they talk about like dry eye and how there's like specific like staining patterns and things like
Mhm.
that, did you find that like there's like when it comes to like NK or corneal nerve dysfunction, there's any sort of like pattern to the staining?
Yeah, I do. Two things that typically will give me pause and make me go check corneal sensitivity because we know, look, my clinic's a little bit different than your clinic versus everybody else's, but flow, it's hard to do on everybody every single time, even though we would love everyone to do it. If I see two things and I haven't already done it for some reason, it makes me check it. If I see central staining only, why would you have central staining only, right? Inferior third, maybe they sleep with their eye open, but if it's central and central only, something's up. Second one is if I see this staining in the middle here in this picture, this is stippling. This is what you see with limbal stem cell issues. And also look at where it's at, superior temporal or nasal, right? If I see staining there, why would I be seeing that? Maybe they've got floppy eyelid syndrome and they're averting when they're sleeping, but when we see that there's limbal stem cell issues and you see this stippling, it's kind of like elongated rice-like, and it can be mixed in with other stuff, right? If you see that something's struggling in that whole cascade that we were talking about, and you probably should check the nerve function. What
Yeah,
about you?
I call it like world like. Yeah, it's like the
Yeah, because this one
epithelial
is
has
actually
like
getting to that
bigger.
whirl-like pattern in the picture. You're right.
Yeah,
Yeah.
sure.
So this is actually a patient of mine. So we call her the hat trick. She knows this. She was on board with it. So she came in. She had RCE, and so I we start treating her for the RCE. She then comes back about 7 days later, 5 days later, because I just want to make sure she's healing properly. And lo and behold, that wound is not closing at all. She's 38, so she's pretty young, right? So she's not healing. So we go ahead and I'm assuming then this is probably also some herpetic function to it, maybe activated some herpes. So I go ahead and put her on antivirals. And then she ends up, as we're doing that, she ends up getting an ulcer. So I check the corneal sensitivity. Lo and behold, yep, stage 3 NK. So this is one of my favorites. She did get a full healing though. So she actually still had a fair amount of scarring afterwards. We ended up putting her in a scleral lens, got her down to 20/20. I didn't do scleral. We know that. We know I sent that to a friend.
We have colleagues that do that. Yeah,
Yes, yes. Oh, I love them.
yeah,
So, with assessment of the corneal sensitivity, the only way that we really know, we mentioned this, right, is the only way we know it's NK, even if we suspect it, is to truly check the corneal sensitivity. And then we're looking, is it normal or is it reduced? It doesn't have to be zero. If it is reduced from what we would expect a normal sensitivity to be, and some of that is just by having done it enough times or between two eyes, we then know that if we've got this decreased sensitivity, we in fact have neurotrophic keratitis.
yeah. I mean,
What?
I tell colleagues, I say, hey, I mean, like, if you haven't done any sort of corneal sensitivity testing, just do it on everybody. So that way you can kind of learn and see what normal response is like, right? I mean, it's hard to tell in the beginning. Like, I mean, going from like, just not knowing what it's supposed to be like to like, checking on an NK suspect, right? I mean, it's try it on a normal person, and you'll be like, oh, okay, this is what it's supposed to be like. And then when you do it on an abnormal person, you'll be like, what the heck? What is wrong? Nothing like nothing.
Great. Yes. Yeah. What is your go-to? Are you a qualitative cotton tip applicator, dental floss, tissue paper, or are you quantitative crochet bonnet,
Yeah.
braille?
So I mean, for me, it's like it's all about being practical, right? I mean, it's qualitative. I run a real life clinic. I don't have time, to check for quantitative type stuff. So we're not a research center or nothing like that. We're not a tertiary care center place. So it's like I need something that's gives me. Do they have any sensitivity? Do they not have sensitivity? Right? Is it reduced? Is it absent? That's the stuff. So for me, it's a cotton tip applicator.
Okay. For me, it is cotton tip applicator or crochet bonnet. I have been using the Brill. I just only have it in one room, so that has kind of slowed things down with that. But the crochet bonnet, I just happen to have them, so that is nice to be able to do that. But in a pinch, guess what? Cotton tip applicator does work. I will say that a colleague of ours did argue for the dental floss and made a really good point. I can
Yep.
have a much more consistent length of the dental floss with a consistent
Yes.
pressure
Yes.
versus a cotton tip applicator, which is absolutely different every time I do it.
It is. It is. Yeah, they made a good point, and I agree. I think that it's if you want something at least somewhat, without the variation of the cotton tip applicator, I think that the same length dental floss, I think that's makes
Yeah.
sense.
And then ideally, I do 4 quadrants in the center. If I've got a patient who's really squirmy or we're having some trouble, I will at least get the inferior, the central, and then if there's some place where I suspect that it's at, like I see a lot more staining, I will test that area specifically. Um, but I try for all I try for all of them.
Yeah. I think in an ideal world, for me, it's just central and then inferior mostly.
Yeah. And here's what you're doing. These are just the options that we were talking about. We actually have a video, I believe.
Yeah.
Yes. Okay.
Hey everybody, I'm gonna go ahead and demonstrate how I do corneal sensitivity testing. We have a volunteer with Bobby here who's graciously agreed to go ahead and volunteer her eyes so we can demonstrate how we do this technique. So what I usually like to do is I like to use a sterile Q-tip, put on some gloves, obviously during this COVID world. And what we need to do is create a wisp. So I'll go ahead and you like to do this little bit of a twisting motion so it allows me to kind of remove the tightly wound cotton tip applicator. And then what I do is I like to create a little bit of a wisp. And then I go ahead and tell the patient to look straight ahead as I get close to their eye. Now, it's kind of important to make sure you don't get the eyelashes because
They will blink.
like, yep, they'll
If
blink and I'm like, oh,
I,
I felt that. I felt
yeah,
it.
and if I have to hold, I'll hold up here versus anywhere in there where I may be causing some kind of
Try to avoid the
feeling.
eyelashes because the eyelashes can definitely feel that. You feel that? A little bit. Yeah. So, and then this is a way to measure qualitatively the corneal sensitivity. Thanks.
There you go. Love it. Good video. So the there's 2 questions and I want to answer them because I think that they're good questions. So NK, if someone has NK, can it also look like they have stem cell deficiency? So I call this the chicken and the egg. Most of the time they're together, or some semblance of them is there together because remember the same trophic support is there to help the nerves as it is those limbal stem cells. So you will often find them together. It just depends on which stage and it depends on the underlying cause if you're going to see one between the other. Distinguishing between the two is going to be your corneal sensitivity. And then if you are seeing some limbal stem cell signs, you see stippling or the specific pattern of staining or seeing it in a whorl like. But honestly, you're going to see them both probably at the same time. And then another question was, how do you differentiate staining in SLK versus limbal stem cell related issue? So they're going to look different just because the SLK is area, specifically area, right? But with SLK, sometimes you will also have, again, limbal stem cell because it's causing damage and inflammation in that limbal stem cell area. So you may actually see both at the same time. Cool. So Prepare Challenge, I think this is something worth talking about for a moment. So when you have somebody who's got pain but no stain, right? Or stain and pain, but you don't see that they make sense. They've got a 10 out of 10 on pain, but you're seeing maybe trace SPK. Look at putting a drop of proparacaine in to numb up the nociceptors on the ocular surface. And if it gets rid of the pain, then you probably are dealing with something on the front surface that is causing that pain, versus if it does not decrease the pain at all or only slightly decreases the pain, you may be looking at something further back in that trigeminal nerve that may be causing that issue, and it may be more of a true neuropathic issue. So that's why I wanted to talk about that one. It's always a good one. Ask Jackie Thies for more info. She's great on that. Give her a plug. Okay, so we have decreased sensitivity. Now what? Finn, what are we going to do? What are we doing for these stage 1 patients?
Well, I mean, it's just like you said here, the always remove the least, right? Do less. It's always, remove the things that are potentially causing, toxicity, like, maybe when you're thinking about your glaucoma patients that are like on multiple drops, or even switching them to preservative-free options, using preservative-free tears as opposed to like preserve, even ointments.
Mm-hmm.
And then obviously treating some of the other issues, right? Like we talked a little bit about limbal stem cells, right? So like, the limbo stem cell patient will be like your contact lens abusers, right? So it's like, hey, you're done with your contact lenses. We'll have to revisit that maybe, 3, 4, 6 months down the road. If they have exposure issues, check that lid seal.
Yeah.
And just, and address those issues, right? So like we'll talk a little bit about the vitamin A ointment.
Yeah, we're going to talk through the specifics on these little guys. Yeah. But we got lots of things. And honestly, you might be going, oh, this is stage 1. Why are we hitting it so hard? Well, it's because we don't want to get to 2 or 3, right? Deal with it now and deal with it correctly so that we don't end up with an open wound or an infection.
Right. So it looks like you're a big fan of this vitamin A ointment.
Yeah.
I mean, I
used
love,
to get it compounded.
Did you? Yeah.
I also use
Good. The only bum part I'm bummed about is that they used to be available on Amazon. So I used to tell my patients,
everything's
go on Amazon, buy it on Amazon, it's easy. And now you get, buy it from the website. But
yeah, you can get it through their website, a couple other websites online. I think Dry Eye Rescue still has some, and there's a manufacturing issue. Nothing got recalled. There was not a problem with, I think, the plant. I think they're just having to find a new manufacturing place. So I that, and then the Optase spray and something else I've not been seeing there either. So you can still find them on some online stores. Like I said, Dry Eye Rescue, My Eyes has them, or helpmyeyes.com. If you have some stocked in your office, don't don't sell somebody a case of it. Hold on to it. We don't know when it's coming back. But the idea with vitamin A ointment is vitamin A specifically has been shown to help with the proliferation and differentiation of corneal epithelial cells. It also helps to preserve those conjunctiva goblet cells. So if I reach for an ointment, I typically do tend to reach for something with vitamin A in it first, just to get that little extra benefit. But we do know that people have some sensitivities to lanolin, which we do have to be aware of that. And that is in most of those ointments that we have available for ophthalmic. What about neurostimulation, neuromodulation? So this goes back to, Ven, you already kind of walked us through beautifully the lacrimal functional unit and stimulating that whole unit through, we've got both we talked about the nasal branch of the trigeminal nerve, and then also there's a way to deal with the ocular surface. Can you walk us through some of these devices?
yeah, so I mean, when we're talking about some of these devices, we're not talking about like addressing, the NK component, because obviously at this time, we want to make sure that we tell people that we don't have enough data or enough literature on it as of yet, right? So this is still sort of like addressing the underlying cause, right? But we felt like it, because of the neurostimulation component, it was kind of nice to be able to address that. So, the first one that came out was, obviously the nose tickler, right? So the true tear from Allergan, and that was based on sort of electrical stimulation inside of your nose, activating the trigeminal, the receptors in your nose to basically stimulate the lacrimal functional units, right? And then you have moving on to the mechanical stimulant, which is by iTear 100 by ophthalmic optics, right? So what they found is that if they apply mechanical stimulation or vibrational stimulation on the outside of where the trigeminal receptors are, they're also able to kind of activate the LFU, which then creates more tears and things like that. So, and then the one that we kind of know more about are the chemical, right, stimulation, which is by varenicline, which is a preservative-free nasal spray, which we activate by spraying the chemical into your nose, and it basically same thing activates the LFU to stimulate more tear production, basal tears, and then stimulate maybe the meibomian glands. Mm-hmm.
So you did mention already, right? We're bringing this up because one, these are treatments that can be utilized to increase, function of activate the lacrimal functional unit, right? Which we know has all of these great all the different components, right? The over 1,500 different, it's got a nerve growth factor, all that good stuff, right? Nerve basal tear. But I also want to say that they did look at varenicline as far as for something to help with neurotrophic keratitis. And unfortunately, it didn't actually show that it improved function of the corneal nerves. But it was a great thought, right? And they're all still looking at different things, and it could have just been a bad subset of patients. But in theory, no, we didn't really see any improvement with the corneal nerve function with it. But you were going to get into this little guy right here.
Yeah, so this is the newest one that's, when it comes to neural stimulation, right? We've got this on the ocular surface, right? So we talked about those nociceptors, and you've got the pain ones, but you also have these cold receptors, right? So the TRPM8 receptors on the surface that basically regulate the basal tear production. And so this eye drop, what it does is that by putting this eye drop on the ocular surface, it causes this sort of activation of the same thing of the LFU, and which then causes this and I've seen a video of you on LinkedIn and Instagram.
Yeah, I'm about 1 month into using it.
Yeah. So I mean, how do you describe this eye drop to your patients?
So describing it, I go into the basics. I'm like, hey, we've got some nerves on the front surface of the eye. When the temperature cools, when evaporation happens when we have our eyes open, right? It activates our body's production of tears. This stimulates that through chemical, right? And so it helps us produce more of these tears that keep our eyes lubricated. Then I give them the heads up that, yes, when you use this, you are going to feel it, right? I'm a month in, it's not like it's going away, but I will honestly tell you it hasn't bothered me. Lasts for maybe 15 seconds. I do in fact feel it. If you've ever used any of the Roto drops with menthol in there, it feels the same. I don't advocate using those, but I have. And it also, or the other way to talk about it is on a cold, brisk day out in the mountains when you get a gust of wind in your eye. Yep. That's about what it feels like.
And just
it's gone within 15, 30 seconds. So it's very tolerable. And it's been working. So that I appreciate. So jumping into stage 2, now we've talked about, what are we going to do for stage 1? Well, guess what? Stage 2 is really not going to change. We're promoting the healing because remember when we go from stage 1, which looks like a dry eye patient, to stage 2, now we have a persistent epithelial defect. And really, we just want to try to promote healing of the epithelial defect by doing everything in the first one. But maybe we're going to put a bandage contact lens on so we can decrease the mechanic rubbing. Maybe we are going to patch these patients. But no matter what, we're going to put a topical antibiotic on these patients because they've got an affected immune system that doesn't know that there's an open wound and isn't going to fight this very well. So we want to promote the healing and prevent infection. Stage 3, well, guess what? Now we get an infection, all the above. We're going to be throwing on some heavy antibiotics. You definitely need to go ahead and culture this sucker, and we're going to potentially need surgery if we get perforation. So let's go into some of these more usable, I personally feel like more effective techniques, such as amniotic membranes and like our autologous serum. When do you reach for the amniotic membranes for these patients?
It's like after I've, run through the battery of like dry stuff, and like it's not getting better with chest corneal sensitivity. I'm like, oh, hey, hello, it's not responding to conventional treatment. That's when I go ahead and say, hey, okay, let's step it up. We need to do something more, and we have the data to kind of back it up, right? So I'll go ahead and the way I explain it to the patients is like, I need to kind of help reset your cornea a little bit, help with maybe some corneal nerve regeneration, and I think we have a slide on that later, but that's when I reach for it.
Yep. So we've got lots of different options, cryopreserve versus dry. Both work well for neurotrophic keratitis. Some of us just have learning curves. I don't do the dry very well. I'm just broken. It's fine. So I reach for my cryopreserved on a very regular basis. I tend to go ahead and put these in immediately when I see these patients if I can. If insurance dictates, I might bring them back in 3 days. But even if I'm going to stage 1, 2, or 3, this is probably going to get added in. And then I'm going to still order the patient the Sinigermin, but knowing that it's going to take probably anywhere between 2 to 6 weeks to get, I don't want to wait. I want to start to kind of, like you said, kickstart this and get it going in the right direction. Have you had any personal experience with I went too far, topical compounded insulin?
I have not, but I've read some good stuff on it. It's just that I haven't quite dabbled in that yet.
Yeah, I haven't either. I've read some great papers on it. Both case reports, obviously, this one is on mice or brain models. I've talked with my local compounding guy, who's my good friend now because I keep sending him papers and saying, "Will you make this for me?" He's willing to make it, but I have not run into a situation where this has been what I reached for versus unfortunately, when I've got a stage 3, I'm reaching for what I know works versus let's try something fun. So that has not been something I've got a chance to. This is just looking at human nerve growth factors. So this is kind of, I've already mentioned Snigerman. This is our FDA, the only current FDA approved treatment for any stage of neurotrophic keratitis, right? So this isn't for stage 2 or 3. While those are what were included in the study, this is something that is indicated for anyone, any stage of neurotrophic keratitis. And so that same nerve growth factor that Vin was talking about earlier, this is kind of mimicking our natural nerve growth factor. They've put it in a bottle for our patients, right? And so the studies do show, and I would echo in clinic as well, that these patients started with stage 2 or 3, and within the 8 weeks of use, because they do this every 2 hours for 8 weeks while awake, it does help to close the persistent epithelial defect. Now, some people do go, okay, well, it's FDA approved for closing of the epithelial defect. What happens to the nerves? Well, in a study, it's really hard to prove nerve function. So that's why they did that. It's because it probably still wouldn't be in our hands at this point if they went the other direction. But I will tell you, clinically, experience-wise, I do in fact notice an improvement in function of those nerves as well, not just a healing of the cornea. What about you, Vin?
No, yeah, totally agree. I mean, I think that's probably reason why they have that as one of the adverse events, right? The patients complain like as soon as they start, they have like this weird, like generalized, like
2 to 4 weeks.
yeah,
Yep. You're going to have tenderness. You're going to have an ache. It's normal, right? And I tell my patients that I'm like, guess what? Your nerves are waking up. This is a good thing. However, if it's red, you have a weird spot in your eye, or you're having a lot of pain and you're just not sure, come on in because I have a low, yeah, just let me
oh,
see. Let's just
yeah.
make sure. Okay, so you've got us talking about tasarrufes here.
So here we've got, obviously, so if you've tried all these medications and all these things that don't work, this is a video of basically my surgeon doing a partial tarsorrhaphy. And it's basically, it's just like what we know, right? It's you're taping the eye, you're sewing the eyelid shut, right? So And you can already see, right? So that patient's got like a like a
Oh,
stage
I can
two.
see it from here.
I
Yeah.
mean, yeah, from here, just looking at this guy, he had this like persistent epithelial defect that would not stay closed. It wouldn't heal. We had run him through a course of Sonergimen and all that stuff, and he still just wouldn't heal. And it's the thing is that one other thing that we have to talk about is Sonergimen is great, but it's very intensive, right? I mean, we're talking about like 6 times a day for 8 weeks.
I had a
They got
patient
like
have a friend come and stay with her to help her with it.
right, because
Yep.
it's not an easy thing, right?
No.
So I mean, sometimes those are all the type of things that you have to kind of think about when you're prescribing these for these patients. I mean, most of the time these patients are elderly, right? So they they have dexterity issues, they've got
Yeah.
arthritis, they've got all these
Yep.
problems. It's not an easy thing. So those are the type
No.
of things. So sometimes it's better to just, hey, let's send them to your local surgeons. They'll sew the eyelid shut, and then that's it. Yep. And scleral
Yep.
lenses obviously could be another option too, because you're just kind of like submerging the eye and protecting in this reservoir of saline that's going to help.
Yeah, I think when I do either one of these, and even when I do Synergermin, we're about to talk about this here, our autologous serum, right? Even if I do Synergermin, I'm still following it up with 8 to 12 months of autologous serum if I can, if it's financially feasible for my patient. But also for those who it's not really, they're not able to do Synergermin, or if you end up doing what you were just talking about with a scleral lens or with having a tesaraphy, this is something that is so helpful for our patients.
Yep.
Yeah. And the reason why is look at all of these things that are in there, right? We've got pH and osmolarity that's similar to our natural tears. We've got the epidermal growth factor, TGF. We've got cytokines, fibronectin, lysozymes, nerve growth factor, all of this stuff that promotes healing and proliferation and function of those nerves. Um, Different benefits of biologics, right? The growth factors help with neurosensory repair, which is specifically what we're talking about. But also remember the underlying issues in these patients are probably inflammation based. So cytokines help with anti-inflammatory, preventing infection. We're concerned for an open wound or somebody who has an infection, right? So all of these things are great for our patients. And we have a couple of different options. We have both the options of an autologous serum, which when it's spun down, it is actually using no anticoagulant. They're just spinning down the red blood cells and removing them, and you're left with the serum as whole, versus going into what's called a PRP, where it's the platelet-rich plasma, where they actually use a coagulant to separate all of the different layers, and you're left with only that top layer versus a PRGF, which has both the platelet-rich plasma, the platelet-poor plasma, as well as they put some activating calcium chloride in there to kind of like make it the super serum, which is kind of cool. I have only experience with autologous serum. Do you have any
Yeah.
experience with PRP or PRGF?
Not yet. We're actually in the process of figuring out how to incorporate it into our because we're already doing some form of PRP for our cosmetic and aesthetic patients already, like in terms of like
Are you
vampire
doing
face
in,
and
are you doing
hair.
injections?
Yeah,
Yeah.
yep.
Yeah.
So, but this is kind of a good segue. We actually had an attendee ask a question about if we have any experience of using whole blood drops, right? So
Yeah.
it's kind of in your graph here, like the finger prick method.
Yeah. So in theory, we don't actually want to do that. And the reason is because there's actually a lot of pro-inflammatory. And that's even the difference why some people argue with autologous serum and PRP and PRGF is that there is still, because of the way that it's made and the red blood cells being damaged during the process, that in autologous serum, we do actually still have some pro-inflammatories. And that's why it's diluted. And that's
Yeah.
also why we don't use over 50%. Now, imagine you've got whole blood and we've got all of these other things that are in there. That is not something we want our patients to be doing is the whole blood.
Yeah. I mean, I will say though that I have had on some occasions use higher concentration of autologous serums, like in the 70 to 80% range. Never 100% yet.
Yeah.
I know some colleagues do use it. Going back to the whole blood, there are some studies out there that kind of indicated that, I mean, it is cheap and effective, right? I mean, they found that, just, pricking your finger and then dabbing that onto the ocular surface has been shown to be kind of helpful. But there's a lot of variables, kind of like what Cecilia was saying. So
There is, and it's, am I 100% against it? No, but the data is like
yeah,
same thing with the higher concentrations. I've had some patients who are like insistent. They're like, I want 75%. I'm like, whatever, do it. Let me know how it goes, right? I mean, 100% I'm not going to do, but those higher concentrations, especially the earlier when I was first doing autologous, I was definitely more apt to do it. Right now, another reason not to do it is if you're getting it through. So my patients go through vital tiers, you just doubled the cost if you go over 40%. So I tend to stop at 40%. I do 20 and 40 because those are the ones that kind of honestly, and most of the time when I've had patients who are on 50% that we were making at the university and went to 40, we just didn't really notice a big difference in efficacy. Yep. So we've got lots of different studies. I'm not going to go into this, but there's lots of different studies. I mean, I did a whole poll for you on data. If anybody wants some data, I'll send you some studies. But there's lots of different studies that are looking at utilizing autologous serum as well as PRP and PRGF for neurotrophic keratitis. And I'm going to let Vin get into his cases here. But if we look at, this is just one of mine who had LASIK, and we put this patient on autologous serum for 8 months at 40%. And we're actually able to see here where those red arrows and the blue arrows are. That's regeneration of nerves and beating from nerves that were, so we've got new nerves, baby nerves, and regeneration of ones that were already previously there.
yeah. So here we have a case of a 40-year-old African male that just basically had severe dryness, filaments, and she was already on the 20% autologous serum, and then I, decided to just kind of switch her over to 50%. She had all of these, systemic issues, lupus, Kasich filament, and we had done all of these advanced procedure, lipoflow tear care, IPL, and she tried all these other drops, taking hydroxychloroquine and doing the nasal spray. And if you go to the next slide, you'll see that, this is what it looked like, right? This is kind of like what you're saying, like, it's just like there's stuff everywhere, right? You've got the filaments, you got things. And after we put on the 50%, it's not perfect, but it definitely helps, right? So those are the type of things is that, even though sometimes when you're like, oh, these patients are already on serum, maybe upping the concentration will kind of help take care of that.
Yeah. And as if any of you were here for last week when I was talking, we know serum is not just for these cases. You can absolutely use it for lots of different things, even our mild dry eye. So it really is a good option for a lot of our patients. But in so much as talking about neurotrophic keratitis, it's not a floater, it's a fly. Check corneal sensitivity when it doesn't make sense. Even when it does make sense, but somebody's not responding, check corneal sensitivity, right? We have lots of different tools for our patients. And don't forget about the powerhouse of our own blood. And here are both of our email addresses. If any of you guys have questions, I know I'm more than happy to answer the best I can.
Thank you both. Somehow you got it all in. With two speakers, sometimes it's hard to get that all done in the allotted time. So thank you. And I will say you even took most of the questions as we went. So I was looking and saying, man, they even answered, which is great because in the moment it's a great way sometimes to do it instead of going back. There was one last question that popped up that I think we didn't get to. It's actually a two-part question.
Yeah.
How do you typically charge for NK when treatments can take a lot of follow-up visits? Is that something that you're billing towards our medical? Is it a global fee? How do you handle that? That's part one.
So there is no global fee for NK. So you are doing a per visit through medical insurance. And I mean, I don't know anybody, if you're cash pay, that's a whole other question, right? But otherwise, you're doing medical visits and it's per visit. There is no global period for things other than, I don't know, Vin, is there a global period for Tasarrufy? I think there
Uh,
used to be, but I don't think there is anymore.
yeah, I think they removed it.
I think they got rid of it like 5, 10 years ago. Yeah. So that's a per visit.
Yeah.
And then the other part of it was do we use goggles, misting night masks, punctal plugs. Punctal plugs, absolutely. Goggles, absolutely. Misting night mask, I don't know that one.
Yeah, it's that thing where it's like basically got a portable
Oh,
like
that's when my patient
humidifier
came in with
with
one of
the
those from
eye. Yeah,
Amazon.
I
And I
think
said,
that's
don't use that because I don't know how sterile you can keep that water. Even though she was putting in like distilled water.
but
I
that's I
don't know.
think
I
that's
don't know
on
about
him.
that. Yeah.
Well, thank you both for an amazing presentation, answering all those questions on the fly. You answered, and there weren't a lot of questions, which usually means that people didn't have a lot because you covered it all. So I want to thank both of you for being here and for amazing cases and distilling a lot of the information into something very simple.